So, good evening, friends. Warm welcome to all of you for this evening session. We have a very eminent national faculty who has joined us for this program today. We have our own senior faculty, Dr. Rajiv Sahai from Hindra Hospital, New Delhi, Dr. Ajay Khanna sir from Varanasi, Emeritus Professor from Banaras University. We have very eminent faculty for the day, Professor Vikas Mahajan, uh, who is the JAE oncosurgeon from the Madras Cancer Control Foundation. Professor Sujay, he heads the surgical oncology at Kaveri Oncology Center. Professor Sandeep Bomidi is Professor of Surgical Oncology at Great Eastern Medical College at Srikakulam. Professor Narendia Hasarat, he is from Gleneagles, Hyderabad. He is part of the DRNB Surgical Gastro Program. And Dr. Raghunandan, again, is an eminent surgical gastroenterologist in the teaching department of NRA Medical College, Mangalagiri, Vizag. So, with the presence of all these very eminent faculty, we have one presentation of obstructive jaundice for the day. The other candidate has some contingency in the hospital, so we'll be having only one presentation for an hour. I'm sure many of you have been served as a faculty here. So we allow the candidate to run through the history part of it without halting. At the end of history, he sums up and you can revisit the slides from chief complaints onwards and ask your questions and give your comments. Friends, this being a teaching module, if the candidate finds difficult to answer your question, I request the faculty to give the right answer according to their expectations so that we can move on. Same way, the clinical finding is allowed to present without any stop. They come to a fair clinical conclusion, then you can revisit the general examination slide onwards, one after the other, and you can ask questions. This gets over in the first half an hour, and the second half an hour is essentially for evaluation, surgical procedure, and complications, and little bit of recent advances. So we have close to 1 hour of time, or little more than 1 hour of time for the day. Today's candidate is kindly contributed by Professor Saravanan sir, head of the Department of Madurai Medical College. We have a case of obstructive jaundice going to be presented, and we have Dr. Hari to present the case today. Dr. Hari, please switch on your video.
Yes,
Introduce yourself. You are head of the unit and head of the department, and start your presentation. Good luck to you. And we have Professor Vikas also joining us now. Warm welcome to all the invited faculty for the day. Please take over. Good luck to you, Dr. Hari.
Yes, sir. Thank you, sir. Share from
Make it full screen, ma.
Yes, sir.
Go to the first slide. You are in the third slide. Dr. Vikas, you are with us, right? I request all the participants who are not faculty kindly mute yourself. Thank you very much. Please start.
Good evening, everyone. I am myself, Dr. Hariharan from Madurai Medical College, second year postgraduate from the Department of Dentistry. My moderator, Professor Dr. Saravanan sir, HOD and HOD, Department of Dentistry, Madurai Medical College. I am going to present a case on obstructive jaundice. History. Mr. X, a 55-year-old gentleman from Vardhanagar, a daily wager by occupation, presented to OPD with chief complaints of passage of high-colored urine for 1 month, yellowish discoloration of eyes and skin for 1 month, itching all over the body for 15 days. History of worsening illness. The patient was apparently normal 1 month ago, after which he noticed yellowish discoloration of eyes and skin, and also noticed by the family members, which is progressive in nature. Passage of high colored urine for 1 month, passage of clay colored stool for 1 month, itching all over the body for 15 days, history of loss of weight, that is lost 5 kgs in 1 month, which is unintentional and noticed by loosening of clothes. No history of abdominal pain, no history of abdominal distension, no history of passage of black tarry stools, no history of breathlessness, no history of headache, seizures, backache, no history of prodromal symptoms like fever, nausea, vomiting, and malaise. Past history, not a known case of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, coronary artery disease, seizure disorder. No history of previous upper abdominal surgeries. No history of any evidence. No history of endoscopic procedures. No history of any chronic
Uh,
drug intake.
Dr. Hariharan, just go a bit slow. You're going
Yes,
too
sir.
fast.
Okay, sir. No history of any chronic drug intake or native medications. No history of tattooing. No history of recent blood transfusions. Personal history. Patient is a smoker for 30 years, smoking index 600, alcoholic for 30 years, non-vegetarian, disturbed sleep due to itching for the past 15 days, normal bowel and bladder habits. Family history. No history of any malignancy in family members like colorectal, ovarian, or pancreatic malignancy. Summary: a 55-year-old gentleman, chronic smoker and alcoholic with no comorbidities, presented with painless progressive jaundice, passage of clay colored stools, itching all over the body, and unintentional weight loss for 1 month with no previous surgeries.
Let's go back to your first slide. So 1 month history
Yes, sir.
and 15 days of itching. 55-year-old daily wager.
Yes, sir.
Okay, next slide, please.
122.
Okay. And weight loss. Okay, next slide. No history of abdominal pain. Why do you take that?
So, in case of cholangitis or in case of any in case of a cold stone in the common bladder, there will be colicky pain will be there. So I ask for
Okay.
abdominal pain, and there is no
Any
history.
other cause of pain in jaundice of this kind? Suppose it's obstructive jaundice. What is the cause of pain in obstructive jaundice without stones?
So in case in case of tumors of pancreas or tumors of head of pancreas or biliary carcinoma, there will be distance distance of pancreas which is called by capsule. Due to capsular distension, there will be pain, and the
Hariharan, please speak slowly.
yes.
Yeah.
In case of tumors of pancreas,
So it is because of head of pancreas infiltrating
it's infiltrating the
into
nerve.
the nerves, right?
Nerves, pancreatic
And
nerves.
it could be, or it could be because of stretching of the Gleason's capsule.
Gleason's capsule.
Okay. Black tarry stool, breathlessness. Okay, these are all symptoms of backache and seizures. These are symptoms of metastasis.
Metastasis.
So just write
Black
straight away because there are other symptoms of metastasis also, right? So
Yes, sir.
just write that no history suggestive of any distant metastasis.
Okay, sir.
Okay, next slide, please. Any history of vomiting?
No history of vomitings.
Any history of hematemesis?
No, sir. No history of hematemesis. No history of vomitings.
Is it important to take this or hematochezia?
Yes, sir. Yes, sir. It is in case of pancreatic tumors, if there is any portal vein obstruction of portal vein, there will be portal hypertension, and there will be upper GI esophageal varices bleed.
Can there be
So,
any other cause of bleeding per hematemesis other than portal hypertension? Portal hypertension is not very common in obstructive and see ahead of pancreas, is it?
yes, sir. Mm.
So what are the other causes of vomiting? Or I'm sorry, vomiting and hematemesis.
Tumors invading the middle wall of second part of duodenum, there will be
Very good.
bleeding from the
Or cea duodenum itself.
duodenum itself, the cause of.
Right. Okay. Uh, Previous abdominal surgeries. Why did you ask for that?
Any upper GI surgeries involving upper GI surgeries and truncal vagotomy or cholecystectomy, any open cholecystectomy or any surgery.
Truncal vagotomy. How will truncal vagotomy lead to this obstructive jaundice? The urine is dark. What about the stool? Is the stool normal colored?
No, sir. No, sir. Stools are pale color, sir. Pale stools. Pale color.
Have you mentioned it? I couldn't come across it.
Yes, sir. Mentions.
Okay, must have. So dark urine with pale stools with jaundice, right?
Yes, sir.
So why should you think of and no okay no what do you call no history of previous upper abdominal surgeries? How are you going to relate this?
Any injury to the common bile duct during open surgeries?
So not truncal vagotomy, please.
Yes, sir. Okay, sir.
Okay. Next slide, please. Okay, it's not alcoholic. He could be consumed. What is the difference in consumption of alcohol and alcoholic?
Um,
An alcoholic he's dependent on alcohol. He'll have withdrawal symptoms,
yes.
right?
Yes, sir.
So it is chronic consumption of alcohol rather
Okay,
than
sir.
alcoholic.
Yes, sir.
Yeah. Next slide, please. Next slide. Okay, so please.
Dr. Hariharan, you said
Yes, sir.
that the patient had lost 5 kg weight
Yes, sir.
and he noted by loosening of the clothes.
Yes, sir.
So are these two things okay? At one side you are saying it is 5 kg weight loss is there and he noted it by loosening of the clothes. He must have weighed himself, isn't?
Yes, sir.
Not by loosening of the clothes, na?
Yes, sir.
Okay. Yeah.
Yes, sir. Okay, sir.
Hariharan,
Yes, sir.
you have told. Sir, yes, sir. Sorry.
Why did you ask about the endoscopic procedures specifically?
Sir,
You've written somewhere, na? No history of any endoscopic procedure.
yes, sir.
What was the purpose of asking that?
So, for any previous history of jaundice for which ERCP stenting something is done or for
Okay. What is the difference between a intermittent jaundice and vaccine waning jaundice?
so in intermittent jaundice, the levels of bilirubin will come to the normal level, and then after that will be there, sir. But in vaccine waning, the jaundice will not the bilirubin level will not reach the normal level. It will be in increasing and decreasing trend, sir, in vaccine waning of jaundice.
So can you tell the cause of intermittent jaundice,
Yes,
which is not because of choledocholithiasis?
um, um, split.
Let us say you are staying in Jammu and Kashmir.
Yes, sir. So,
Any parasitic infection, okay?
capacity.
Ascariasis is there, and that can cause the intermittent jaundice,
Okay, sir.
but not because of choledocholithiasis is the commonest cause for that. No?
Yes, sir.
Okay. Dr.
Hariharan?
Bhamidi, you want to
Other
ask? Yeah.
faculty
Yes, sir.
would like to ask something. Please go ahead,
Yeah.
sir. Please
Yeah.
feel free to
Yeah.
ask that.
Yeah, Dr. Hariharan, please go to the first slide after
Yes,
the
sir.
chief complaint.
Yes, sir.
So you told apparently normal. There will be no like apparently normal. It should be apparently asymptomatic.
Okay, sir.
And you told it is progressive. You did not told about onset. Onset. What is an onset? Whether it is insidious in onset or sudden onset. And you did not describe the jaundice, how it is a jaundice, whether Sarah has rightly told whether it is a waxing and waning episodes are there, or it is a painless progressive jaundice, or a painful progressive jaundice. These you did not mention anywhere. And while doing the prodromal symptoms, you kept it as a last after the metastatic symptoms. Better you rule out before the metastatic symptoms, so that the examiners will get the clarity that you are ruling out an acute episode of any cholelithiasis or cholelithiasis or any cholecystitis.
Okay.
So, and you told history of loss of weight and lost, as Sir rightly told, Professor rightly told, 5 kgs. You told he is in, how he has, before he has weighted the weight, and after that he has weighted the weight, and he told he has lost 5 kg. You have calculated before and after. Before means before his symptoms and after his symptoms.
No, sir.
Don't tell. Yes, you told lost 5 kgs in 1 month, which is unintentional and noticed by loosening of clothes. Both can't be combined. Either of these you should keep.
Okay, sir.
And please come to the next slide. As I told, these all, Sir rightly told, you did not ask about hematoxesia, all other symptoms of portal hypertension, and you did not ask. These prodromal symptoms would have been better. You should have told that at the table of abdominal pain.
Okay, sir. Okay.
And you asked, come to the family history. Why you asked family history? History of colorectal and other malignancies.
Yes, sir.
Which thing you are seeing?
Sir, sir, in BRCA2, the pancreatic malignancy, risk of pancreatic malignancy is more. In colorectal malignancy also, HNPCC, risk of pancreatic malignancy is 100%.
HNPCC.
HNPCC.
And which mutation, which is the most common mutation that will cause pancreatic cancers? You, while speaking also, you make sure that speak slowly, don't feel tensed.
Okay, sir.
BRCA mutation. You have to rule out most is BRCA mutation and familial pancreatic cancer. Thank you.
Again, in your prodromal symptoms, can you just go to that slide?
Yes, sir.
Where you're showing the prodromal symptoms?
Yes.
Now, out of this fever, nausea, vomiting, malaise, you know which is the commonest prodromal symptom which you have not mentioned? You have mentioned all others.
Yes.
What you have not mentioned? Is that
no
change in the appetite or distaste for the food? Okay. That is the commonest prodromal symptoms which is there.
Okay, sir.
Then all those others will come. Na?
Okay, sir.
Okay, yeah.
Okay, sir.
See, in summary, you didn't mention about cholangitis. That is important, basically. So,
okay,
important point, you have to mention, always mention about cholangitis.
Okay, sir.
Please continue.
Okay, sir. General examination. Patient is conscious, oriented to time, place, person, and febrile. Moderately built and nourished. Hydration adequate. Height 160 centimeter. Weight 55 kg. BMI 21.5. ECOG 1. On examination, ictus present. No cyanosis. No clubbing. No pedal edema. No generalized lymphadenopathy. Vitals BP 130/80 millimeter mercury. Measured in sitting posture in the right arm. Pulse rate 68 per minute. Normal in rate, rhythm, volume, character. No radial delay, radiofemoral delay. Saturation 98% measured and room air. Examination of abdomen, inspection. Abdomen is not distended. Umbilicus in midline. All contents moves equally with the respiration. Visible fullness noted in the right hypochondrium, extending into the umbilical region, moves with respiration. Yellowish discoloration of skin and scratch marks seen over the abdomen. No visible gastric peristalsis, no visible pulsations, no dilated veins. Hernial sites free, flanks free, both renal angle, no fullness seen. External genitalia appears normal. Left supraclavicular fossa free. Palpation, no No local rise in temperature, no tenderness. All inspectory findings were confirmed. Gallbladder of size 5 cross 5 centimeter palpable below the right costal margin. As a smooth surface, moves with the respiration. Upper margins could not be palpated. No hepatosplenomegaly, no other palpable lump. Both hernia sites are free. Flanks are free. Both renal angles are free. External genitalia are normal. Left supraclavicular fossa, no palpable lymph nodes. Percussion, dull note heard over the mass. Liver span 10 centimeter. Liver dullness continues with the mass. No free fluid. Auscultation, normal bowel sounds heard. Perineal examination, perineal skin normal. No skin tag, fissure, fistula. Digital rectal examination, sphincter tone is normal. No growth. Deposits, no growth or deposits palpated. Mucosa freely mobile. Prostate normal. Pale stool stained on the gloves. No blood stain on the gloves. Other system examination, cardiovascular system, S1, S2 heard, and no murmur. Respiratory system, bilateral air entry present, normal vesicular bed sounds heard. CNS, no neurological deficits. Professional diagnosis, case of obstructive jaundice, probably due to carcinoma head of pancreas. The differential diagnoses are perineal carcinoma and cholangiocarcinoma.
Hariharan, please go to the first slide.
Yes, sir.
Renal examination. I think you better tell about BMI, hydration, and performance status, because moderately built and moderately nourished, I think these words are now come to this thing. Better you tell only hydration, performance status, which is you told ECOG 1, and
Yes, sir.
BMI. So that
Yes, sir.
for sake it will be this thing. And where you have seen icterus in this patient?
In this sclera, sir.
Sclera.
Yes, sir.
Sclera. Which part of sclera?
Sorry.
Bulbar conjunctiva.
Yes,
So
sir.
you did not mention about pallor. If you want to see pallor in this patient, you have seen the pallor or not in this patient?
Sorry, in patients with jaundice, if icterus is present, pallor will not be visible. So
don't feel tensed. Where you will see pallor in this patient? Yes, agreed with your statement, but where you will see pallor in this patient? You examined the patient. You examined the patient.
Yes, sir.
So where you have seen? You have seen or not seen?
Yes, sir. Seen.
Where you have seen?
So, if you want, pallor will be seen in the nail buds. I can see the nail buds.
So you told it is an yellowish discoloration of all the skin.
Yes.
As I remember, you told it is all over the skin.
Yes.
Best site is under surface of the
tongue.
So that is the best site. And which signs you have seen for liver failure? You told no signs of liver cell failure.
Yes,
which
sir.
signs you have seen for liver cell failure?
Palmar erythema.
Head to toe. Yes, you come from head to toe.
Okay, sir. So no encephalopathy, sir. Altered sensory, no encephalopathy. Patient is conscious. Skin spider nevi on the skin. Palmar erythema in the palms. Testicular atrophy.
Head to toe. If you come from head to toe, you will not forget.
Okay, sir.
Why I told this? Because it is this thing. Because you will never forget if you take from head to toe. If you go from haphazardly, you will definitely forget.
Palmar erythema on the palms.
Whatever you know, you tell. No issue.
Dilated veins was abdomen. Abdominal distension, testicular atrophy, and lymphedema. Edema of the lymphedema.
I think please once you read gynecomastia, you did not mention, but please once you go and once you revise, no issue, but once you revise. And you told generalized lymphadenopathy. Which lymph nodes you have palpated? When you call it as a generalized lymphadenopathy?
More than 5 groups.
More than?
5, 3 groups of lymph nodes.
More than 2 non-contiguous lymph nodes. Non-contiguous lymph nodes. Please come to next slide. See, abdomen, you have to tell is not distended. I think that's not a right word to use. Let the process also is abdomen is either you tell flat, scaphoid or something. Abdomen is not distended. I think it's not a right word.
Okay, sir.
And all quadrants move equally with respiration. Will the lower quadrant move with the respiration?
Yes.
You can mention all corresponding quadrants moves with respiration.
Okay, sir.
Equally, I think these words, I think you need to use properly. All corresponding quadrants moves with respiration.
Okay, sir.
Whichever the quadrant is there, it moves with respiration. Come to the palpation. Before slide, please, before slide.
Okay, sir.
Hariharan,
Sir.
Yes, sir.
you
Sorry.
not mentioned about contour of abdomen.
Sir. Sorry, sir.
You are not mentioned about contour of abdomen.
Contour.
What is normal contour of abdomen?
Sir, abdomen is not distant, no distance in the abdomen.
So, how to mention it? What is normal contour of abdomen? It is neither contracted nor retracted. Shape is a square shape.
Scaphoid.
Okay, proceed. Continue, sir.
Sorry, you told left. So why you all asking left supraclavicular fossa?
Sir, if there are any palpable lymph nodes, there will be fullness seen in the left supraclavicular fossa.
Only left, right will not be there.
Sir, left supraclavicular, which node will be present in the left supraclavicular fossa? So level 4.
Why? What is the pathophysiology of Werkho's node? Werkho's node?
Sir, via the thoracic thoracic duct, where the azygos vein, the tumor cells goes to the thoracic duct and it enters the junction of left brachiocephalic and subclavian vein. From the junction during regurgitation, the tumor cells goes and deposits in the Werkho's nodes, which is in the left supraclavicular fossa between the two hertz sternocleidomastoids.
You can make much more with clarity. I think you need to have more clarity on that. And you mention, you don't mention only left. Supraclavicular fossa is free. Bilateral supraclavicular fossa is free.
Okay, sir.
Because it's not like left. It may rarely come down to the right also.
Okay, sir.
Next slide, please. Next slide, please.
Can I just add one more point on that?
Sir. Yes, sir.
Yeah. So sometimes you have a lot of variations in the lymphatic channels. So that is why you can have right supraclavicular nodes, and they are not very uncommon also.
Okay,
So
sir.
that is one of the points. And one more point I wanted to add earlier itself, because this for hereditary, especially if you have polyposis coli,
Okay, sir.
endoscopically you may find some polyps in the periampullary region and they can turn into cancer. So
Okay, sir.
patients who have undergone surgery, total colectomy for these polyposis, multiple polyposis coli, they are screened regularly in their follow-up for periampullary carcinomas. So that is
Okay.
a hereditary this thing. That also, as you said, that there is no hereditary colorectal cancer. That is the reason for that.
Okay, sir.
Okay. Yeah.
Thank you, sir. Okay, sir.
How you will measure liver span?
Yes, sir. We have to percuss from the midclavicular line, from the second intercostal space. The resonant node will be heard. When there is a first dull note, we should mark that is the upper limit of liver, and we should focus down along the along the mid axis to the mid axis line. We can measure the dull note up to the dull note. We can measure the
Dr. Hariharan, I'll just stop you here.
Yes.
This is Dr. Sai. What's the normal liver span?
So 10 to 12 centimeters, 10 to 12 centimeters, sir.
And how much is this person's liver span?
It's about 10 centimeters, sir.
Why do you think with so much of jaundice he still has his liver shrunk?
Now, normal limit only, sir, 10 to 12 centimeters. Liver span is it's a normal limit, sir. His liver span is 10 centimeters. It will be normal limit.
What's the normal liver span?
10 to 12 centimeters.
So can you think of a reason why the liver is not enlarged here?
Sir, he's a chronic alcoholic, sir. So there will be liver cirrhosis also.
So there is fibrosis, and that could lead to right.
That's not liver enlargement.
Okay, this is palpation. Is there any ascites there? Have you mentioned ascites?
No, sir, no ascites.
Have you mentioned it?
Sir, in percussion, I mentioned no free fluid.
No free fluid where? Okay, you should write. No, okay. Okay.
And Hariharan, small this thing. Sorry, sir. When anybody is asking what is the liver span, how do you calculate? You be ready how you will tell in the exam. Either you don't feel like that, you should not tell like that. You should come like fort. You should come like that.
Okay.
So now you can't think.
Okay, sir.
If any examiner or professor is asking you what is liver span, you have to before only you should decide what to tell. Now you can't tell in between adjectives. Suddenly you don't think. Huh?
Okay, sir.
That is what I want to tell.
Okay, sir.
Excellent presentation.
Whenever you have to tell about the liver span, you have to always tell that at what level you are measuring.
Okay, sir.
Okay, whether it is in the mid-clavicle line or whether it is in the anti-exit line or the mid-exit line or in the epigastric region.
Okay, sir.
Because the liver span will vary according to the site.
Okay, sir.
Okay, the commonest site is the mid-clavicle line, where it is around 11 to 13 centimeters.
Okay, sir.
Okay.
Okay,
but
sir.
Like if there is a lump in that area is there, then you cannot measure at that area. So
Yes,
you have to move to the anti-exit line.
Yes, sir.
There it becomes 13 to 15 centimeters.
Okay, sir.
So you have to always tell about at what level you are telling the liver span.
Yes. Okay, sir.
Okay.
Okay, sir.
Finger is insinuated or it's continuous? Finger can be insinuated.
Sir?
What is the mass? Whether you can feel the upper border, it is continuous with the liver or it can be insinuated?
It is continuous with the liver, sir. You cannot insinuate by finger.
Okay. Thank you. Continue with your provisional diagnosis.
It's a case of obstructive jaundice, probably due to carcinoma head of pancreas. My differential diagnosis are periampletic carcinoma and cholangiocarcinoma.
Why you are thinking it is an obstructive jaundice? Due to only malignancy. Why not? It is a benign thing.
So in case of this patient is having a painless or progressive jaundice, sir. In case of benign,
you have mentioned that thing, painless progressive jaundice in the history.
Yes.
Okay. So one is painless progressive jaundice, and next is why not? I will call it as a choledocholitis. What are the points in favor of choledocholitis? What are the points in negative for choledocholitis?
Obstructive jaundice is present. That is a feature of choledocholitis, sir. But in choledocholitis, there will be intermittent jaundice, sir. But here the jaundice is progressive. So
means in malignancy there will not be intermittent jaundice.
No, sir. In periampletic carcinoma there will be waxing and waning of jaundice.
So you tell from the history and the clinical examination. In history, which points favoring the any points are there for favoring choledocholitis or not? Or any points that are favoring malignancy or not?
Yes, sir. History of
if any examiner is asking why you called it as obstructive jaundice, you have to tell points in favor of history, points in favor of examination. Points negative in terms of history, points negative in favor of examination. So start.
So points in favor of history, sir, for malignancy. There is progressive jaundice. There is history of weight loss. There is a passing of pale colored stools.
Whether any weight loss we will call it as a malignancy. What is the important in weight loss?
So significant weight loss, sir.
When it is called a significant weight loss?
More than 10% of weight, loss of weight in 6 months.
10% in 6 months. In 1 month?
That's a 5 kgs in 1 month.
5 kg or 5%?
5 kgs in 1 month.
5%.
5%.
Okay. Continue.
In points in favor of points favor an examination. That's a there is a palpable mass. Palpable, that is gallbladder is palpable, and the
whatever the mass that you are
is hard.
palpating, that is you are thinking it as a palpable gallbladder.
Yes. The gallbladder is consistency of the gallbladder is hard.
It is hard or tense?
Hard.
Okay. So what is curvoresis law?
In case of in patients upset, in case of jaundice, palpable gallbladder is not due to stones, cold up, not due to.
It is a law. You should tell it like as law. Please continue. Please tell again.
When there is jaundice, there is a palpable gallbladder. It is not due to.
In a patient with obstructive jaundice, if gallbladder is palpable, it is unlikely to be stones. It is a law. You should term it as a law. You should tell it as a law.
Let's say in periampullary carcinoma, there can be vaccine intervening, but it's not always present. It will be only in 30% of patients. So you can't tell in every patient if there is vaccine and waning only you can say periampullary carcinoma. If vaccine and waning is there, it is due to periampullary carcinoma. But reverse is not true. Okay, it can be seen in only 30% of the patients. And periampullary carcinoma, you can see clay colored stools. Why you will say clay colored stools?
Reason for pale colored stools, sir?
In periampullary specifically, you will see the clay colored stools. Usually, you will see pale colored or white colored stools. So in periampullary, you see about clay colored.
Yes, sir. Sir, due to the tumor outgrows its blood supply, sir. So there will be bleeding from the tumor site. It will cause melena. So stay away with melena. It will cause clay colored stools.
Yeah. And you said here painless progressive jaundice and your first probability is carcinoma head of the pancreas. Why can't it be periampullary carcinoma?
Sir,
what is the incidence of pain in head of the pancreas? You only said carcinoma head of the pancreas will be painful.
No, in advanced stage, will be painful.
No, it's not like that. Usually, 2/3 of the patients with the carcinoma head of the pancreas will have pain. Periampullary will be usually painless.
Yes.
So, distal cholangiocarcinoma also usually painless. Hilar will be painless, and carcinoma gallbladder and carcinoma head of the pancreas will be usually painful. So, around 90% of the CAGB with obstructive jaundice will be painful because of gallstones and all those things. And the second, carcinoma head of the pancreas will be painful in 2/3 of the patients. In periampullary and distal cholangiocarcinoma, usually 1/4 of the patient will present with the pain. Otherwise, they are painless jaundice.
Okay.
So why will the patient of CA head of pancreas have pain?
Due to the infiltration of retrosplanchnic nerves.
That is the only reason?
Enlargement of due to the distance of pancreatic capsule, there will be.
No, it's basically in pancreatic cancer, one of the main features is the blockage of the pancreatic duct. So every time the patient eats food, automatically the pancreatic duct distends and that causes the pain. So that is one of the reasons. Other than the ones, of course, the nerves will get infiltrated, it becomes advanced and all. It's not that in periampullary and all it will not happen, but only in the late stages.
Okay.
Okay. Yeah.
Okay.
Go ahead. You are doing well.
I would like to confirm my diagnosis. So I did ultrasound abdomen. In ultrasound abdomen, there's a gross IHBR dilation, grossly descended gallbladder, CBD diameter 21 millimeter. Distal CBD is not visualized. Main pancreatic duct is 5 millimeter and no ascites. OGD scopy done. It's normal steady.
So ultrasound, what are the things you will see?
So in ultrasound, I can see the site of the lesion. Site of the lesion about the gallbladder thickness of the gallbladder, whether there is any pericholistic inflammation, if there is any ascites, or there is any liver metastasis.
On ultrasound, how can you say it is a medical jaundice or a surgical jaundice?
First,
On ultrasound,
Yes, sir.
how can you say it is a medical jaundice or a surgical jaundice?
The size of the liver, based on the size of liver.
no.
Size of the liver may be large in both, but what you will see inside the liver?
So intrahepatic biliary IHBR dilatation, sir.
Yeah, so that is the most important thing, na?
Yes.
So if you find that dilatation is there, then it is probably surgical jaundice, na?
Yes, sir.
If it is not there, then it is likely a
Medical.
hepatocellular jaundice, na? Okay.
Okay, go ahead. What you will do
What is
next?
a double duct sign?
Sir, in case of carcinoma head of pancreas, both CBD and pancreatic is obstructed. It will be seen as a double duct signs.
So in a case of periampullary carcinoma, you cannot get the
Yes,
double
sir.
duct sign?
Yes, both pancreatic, main pancreatic and common bile duct both is dilated, sir. That is it.
So in which type of the periampullary carcinoma you will get the double duct sign? You know, what are the various types of periampullary carcinomas?
Within 2 centimeters from the ample of that,
Yes. What are the various types? It is 2 centimeters in the ampulla. But what are the various locations?
4 times. 1, 2, 3, 4. It should just come out in 2 seconds. Yeah. There is nothing complicated in that. You have to look at periampullary and say, yeah.
Okay, it may be ampulla, it may be duodenum, it may be bile duct, it may be pancreas, head of pancreas.
That's all.
So in which variety you will get of the periampullary carcinoma, the double duct sign? Will you get the double duct sign in the case of the duodenal variety?
Yes, sir.
No, you will not get.
No, ampulla is not blocked. Whenever blocked, common channel is blocked, you will get the double duct sign.
So either it is a carcinoma head of the pancreas within 2 centimeters, or it is the ampullary variety.
Yes, sir.
Okay, you will get the double duct sign. If it is a cholangiocarcinoma is there, or it is a duodenal carcinoma is there, then you will not get it.
Yes.
Okay, yeah.
So it is not a all or none law. In all these cancers, you may get a double duct sign, but in duodenal and bile duct, it will be in the later stages.
Okay.
So that is what is being pointed out. Okay.
So in USG, you did not mention any. What is the liver? What is the status of the liver? Liver is normal or not?
तुम क्या स्विमिंग करके आ रहे हो क्या?
Liver is normal.
Yes.
You have taken the points from the USG, or USG is like this only?
USG is like this only.
Okay. So liver is normal. There is no ascites.
Yes, sir.
And IHBR. Okay.
So next, blood investigations. Total bilirubin is 30.7 milligram per deciliter. Direct 15.3 milligram per deciliter. AST 59 units per liter. ALT 42 units per liter. ALP is elevated 639 units per liter. PTNR 11.1, INR 0.9, sodium and potassium 130, potassium 3, urea and creatinine normal within normal limits. Blood sugar is 95 milligram per deciliter. Tumor markers CA99 and CA has to be done.
So what is the significance of AST ALT?
Sir, AST ALT is more towards it is increasing in alcoholic hepatitis, sir. But ALP is significant for obstructive jaundice, which is elevated most.
Okay.
The question is, what is the significance of AST and ALT? Can AST ALT be high in periampullary carcinoma or in these patients?
No, sir.
In what situation it can rise? It can rise. What is the cause for the waxing and waning of jaundice?
Tumor outgrowth is blood supply, sir. So there will be a sloughing out of tumor. At the time, the obstruction will be relieved. Then there will be waxing, and if
so when this happens, you can have infection also. So
yes,
if
sir.
you have infection, you will have pancreatitis or cholangitis.
Yes.
Cholangitis, your AST ALT will increase.
Okay.
Okay, so
Yes.
it is not a all or none. But what is the significance of AST and ALT? That is the question. Each liver function has a role. So in this, it is looking almost normal.
Yes.
So in which condition it will rise and why?
Hepatitis.
So in hepatitis, okay, but why will it rise? See, it's basically a indicator of liver damage. So if your liver cell damage is there because of whatever reason, the AST and ALT will increase. Alkaline phosphatase, why does it rise?
So alkaline phosphatase, usually cholangiocytes hepatocytes produce alkaline phosphatase, sir. So it is also
the bile ducts, they produce this because it is blocked, it goes into the blood and increases. Okay.
Yes.
That is the reason. Yeah.
Yes.
Is there
Go ahead, sir. Yeah.
Anything you want to know from the blood investigation, which is very important? You have missed in LFT. LFT. You want to know anything?
Total bilirubin is elevated, sir. ALP is elevated.
Albumin levels.
Albumin levels.
It's a protein
albumin levels. A and A by G ratio.
A by G.
Okay. Very important. Very important in these chronic cases. You need to be very, very careful. And bilirubin is 30. That is direct is 15 and indirect is 15. As you mentioned, I will take it as indirect is 15.4 because direct is total bilirubin is 30.7. That is the value?
Yes, sir.
Okay.
What is the significance of albumin? Why is he asking you that question?
Sir, albumin is produced from the source of albumin is only liver, sir. If there is any liver damage, albumin production will be low, sir.
What else is the significance in a
postoperative? In postoperative period, serum proteins are postoperatively normal serum protein levels is essential for anastomosis.
See, it indicates the nutritional status of the patient. Albumin does not improve immediately if the patient is given high protein diet, but it indicates a chronic status because the liver is damaged. That is one part of it. And the second significance is not the serum protein, it is again the albumin. If the albumin is low, wound healing, your anastomotic healing can get compromised. Okay. Yeah. Go ahead.
CCT abdomen was done with pancreatic protocol. In CCT, over-descended gallbladder is seen. Maximum diameter of count value is 2.4 centimeter. Main pancreatic maximum diameter 0.8 centimeter. 2 cross 2.7 centimeter measuring ill-defined heterogeneously enhancing mass lesion noted in periapital region, predominantly in distal CBD, causing common bile duct, main duct, and IHBR dilatation. That's the findings.
So what are other things you will see? You mentioned about only about primary tumor and these things. So what are the things you will see in CT?
Sir, we can see for nodal status, sir. Nodal metastasis. Any nodal metastasis we can see for nodal metastasis, sir.
What are the node metastases you will see?
Any node nodes around the portohepatitis we can see for the parietic nodes. Other nodes, and we can see the level of in CT we can find the level of obstruction in the common bile duct. That also we can find out, sir.
Here also same like ultrasound. You didn't mention about the liver status here.
Liver status.
And you didn't mention about free fluid. We didn't mention about parietic lymph nodes. You didn't mention about variant arterial anatomy here. So all these things are important when you go for planning.
So easy to remember, Dr. Hariharan. Very easy to remember. When anybody examiner is asked you, what you will see: tumor, node, and metastasis. You have described the tumor. You did not describe about nodes. You did not describe about metastasis. It's as simple as that. So you just remember like that. So there will be no confusion, and there will be no forgetting of things. Tumor, node, and metastasis.
Okay, sir.
And very, very important, you need to see about the arterial anatomy.
Yes.
Where is the branch of celiac artery coming? Where it is your common hepatic artery is coming? Where is the right hepatic is coming? Where is the left hepatic is coming? It is coming from SMA. Yesterday only we operated one case. The right hepatic is coming from the SMA.
Same.
That is very, very important. That is very, very.
Why it's important? Why variant arterial anatomy is important?
For tumor resectability, sir. Whether the case operable or inoperable, we can.
How?
Sir, if the tumor is if there is any tumor invasion.
No, it can be with a normal arterial anatomy also. Why specifically with the variant arterial?
Sir, sometimes the right hepatic artery will be arising from the gastroduodenal artery will be arising from the right hepatic artery. In that case, ligation.
I think no, don't confuse that, Haren. Today, when you go to the home, you just read what are the branches of celiac artery, what are the branches of SMA, what are the branches of IMA, and what are the variant anatomies that can be possible. You stick it in your room.
Okay, sir.
And you read tomorrow also, you read after 5 days also. Then only you will remember. Okay. Otherwise, you will not remember.
I just wanted to add one more thing, is that you have to know what you want from the CT scan. So when you are asking for a contrast enhanced CT scan, what exactly are you looking for? You will get a single picture or a 2 pictures in which either the arterial phase is there or you have only the non contrast phase. So what exactly you want in the this thing, what is the cut size, those things are important as a surgeon for you to know, otherwise you will not get that information properly. So in a pancreatic cancer or a periampullary cancer, you need to have a 3-phase contrast enhanced CT in which there will be an arterial, venous and portal venous phase, which is very important both for the liver and for the pancreas, because the commonest metastasis is in the pancreas, and the arterial anatomy, the venous anatomy is very important for you to plan the further surgery.
Yes.
Okay. Yeah.
And what is pancreatic protocol CT scan? What is pancreatic protocol CT scan? SAR is rightly asked.
Yes, sir. It is usually a 3-phase scanning, sir.
And another, my request is don't keep CECT, don't keep like that. Contrast enhanced computerized tomography of abdomen and pelvis.
Okay, sir.
Please write like that because it will be this thing. Please tell.
Okay, sir. It is a triple phase scanning. First arterial phase, 20 to 25 seconds. Then pancreatic phase, 35 to 40 seconds. Then portal venous phase, which is 60 to 70 seconds, sir.
And what is the slices?
A slice will be less than 3 mm size slices, sir.
Excellent.
Excellent. Yeah, very good. Next slide, I think.
So that's all.
So according to CT, is it a resectable tumor or not?
We have to see. We have to look for status of the. Sir, I didn't mention in this PPT, sir. There is no encasement or invasion of any major arteries.
Okay. Is patient clinically resectable?
Yes, sir. There is no there is no ascites or metastasis or no artery involvement. So
See, Hariharan. Just clearly, Sir has asked, Dr. Hazrat Sir has asked, is the patient is clinically resectable or not? You tell
sir,
yes or no.
No, sir. No, sir.
Why no?
Why?
Or why yes? You told yes. Again, you change the word to no. Okay, agreed. No. Why no?
Sir, no, sir. Sir, because patient is icteric, sir. The bilirubin levels at 30.7, sir. So first we have to reduce the levels of bilirubin, and then we have to optimize the patient for surgery, and then we have
What is called excellent? You told excellently optimize the patient. What you will optimize the patient? Please tell which factors you will optimize the patient.
For correction of bilirubin, we have to do any stenting procedure, sir, to relieve the obstruction.
I told what you will optimize the patient. So as you see, Hariharan, you need to understand. I told one thing: performance status,
Yes,
hydration, nutrition.
Yes, sir.
That's
Hydration.
right. The same things you will optimize.
Yes, sir.
The same things you will optimize. Nutrition you will optimize. Hydration you will optimize.
Yes.
And bilirubin will decrease. So Hariharan, you don't confuse. You are excellently answering. Don't feel tensed. You are doing absolutely well. Just be calm and you answer the questions.
Don't give explanation first. Give what are the specific you want to tell. So if you are asking what optimization you done, you will do. So just a nutritional, just a biliary, just like this. Then you can ask what nutritional optimization you will do, how you will do biliary optimization. Then you can answer.
So there will be two as rightly Sir told, there will be two advantages to you because the examiner will take another question to you. So you have passed one question, two questions will be done for you. The examiner will also feel you know more. So it will be better.
Okay, sir.
So if you tell everything before only, then examiners will ask different questions. Then it will be again different for you.
Okay, sir.
Continue.
We have hydration and nutrition, and then
so bilirubin is 30. What do you want to do in this patient? In this patient, you want to optimize the bilirubin. How you will optimize the bilirubin?
We can do any stenting procedures, sir, to relieve any obstruction.
Which stenting you will do?
ERCP is ERCP and stenting. ERCP.
What stent will you use? That is what he's asking.
Plastic sensor. Plastic stent. Plastic.
Okay. And is there anything called respiratory optimization also?
Respiratory.
So any major surgery, you have to do all these three things, which already sirs have already mentioned about the jaundice, about the nutrition and the hydration. But in addition, for any upper abdomen surgery, you have to also optimize his breathing ability. Remember, he's a smoker, you mentioned.
Yes, sir.
So you need to prepare him. If you are going to plan surgery, you've got to prepare him. Yes. Otherwise, post-operatively, you will be in trouble.
Yes. Breathing exercises and central parametry I can size patient.
So what after optimizing the patient, when you will take the patient?
So when the bilirubin levels are less than less than 10 below 50.
Means how much time will be you take after putting a stent? After how many weeks you will operate the patient? I'm asking that question.
6 weeks after.
Agreed. 4 to 6 weeks.
4 to 6 weeks.
What all problems are you likely to face because of the stenting?
So during surgery, yes.
No, one is during the procedure or after the procedure and during surgery.
During the stenting procedure, or
Yes, just after the stenting procedure, what all you can face? See, you optimize, you want to do surgery for the patient and you have sent it for stenting.
yes,
And the stenting is done and the patient comes back to you.
yes, sir.
Suddenly, lot of problems happen. What problem can occur? That is what I'm asking.
Stenting day one, the patient is having pain abdomen.
Already Sir has given the clue.
Any ERCP stenting procedures will have some complications,
Yes,
no?
sir. ERCP, post ERCP pancreatitis will be there, so patient has developed abdominal pain abdomen, sir.
Yeah.
Excellent.
And then during surgery, what problem can you have?
Adhesions will be there, sir.
Yes.
Why should there be
These fibrosis and adhesions will be there, sir.
So you will have inflammation, not adhesion. You will have inflammation because of the infection which will be introduced by the stent. And when you have inflammation, you will have more oozing during the surgery. So that is and then post-operatively you can develop cholangitis also. This infection which will be there can flare up and cause very severe septicemia also sometimes if you are not careful and not given the appropriate antibiotic prior to the treatment surgery.
Okay, sir.
That is, sir, as Vikas sir said, that is drop trial is there, randomized trial. So in the trial, they have taken bilirubin less than 15. If you do stenting, without stenting, if you do surgery, there are high risk of leak and cholangitis, all biliary leaks, all are more common with stented patients than the non-stented patients. So that's why usually if bilirubin is less than 15 or sometimes now it is going up to 20, 25 also, if there is no cholangitis, we are going directly with the surgery than going for stenting because you are inducing the infection by doing ERCP and stenting.
Okay.
Yes. That is always a debatable point, as Doctor rightly told. But from general surgery perspective, you just tell what is your institutional protocol.
Yeah, anything above 15, you are okay to say stenting can be done. So the other reason can be the patient's general condition is not very good because his nutrition is not okay. They have gone to some quack and had some other treatment. Then their general condition. Then you have to do the stenting to buy time basically.
Yes, sir, rightly told, more than 15, better to go for a stenting. In this patient, is 15.4, again a dicey patient. Which surgery?
CA99 level in this patient?
Sir, CA99 level has reports are yet to come, sir. CA99 yet to come, sir.
Is a diagnostic marker or a prognostic marker? Because time is up.
Diagnostic markers.
CA99 is a diagnostic marker.
How will you diagnose with CA99?
Sir, it is elevated in pancreatic cancer.
Means it is not elevated in cholangitis. See, Hariharan, this is only a prognostic marker. As time is up, I'm just fast forwarding it.
Okay.
It's only a prognostic marker. Preoperative CA99 levels will tell about the prognosis of the patient. You read about A, B, C of pancreatic cancer.
Okay.
A, B, C. Anatomy, biology, and conditional. ABC of pancreatic cancer.
Okay.
And another thing, which surgery you will do?
So I'll go for modified Whipple surgeries.
Modified Whipple. What is modified Whipple? That's why I don't add any angiotensin. I'm telling you, it is a leading. I'm telling you, it's a simple thing. If from you only will ask questions. We also don't want to ask any questions. From your words only will ask you. That is a simple funda. Modified. What is modified Whipple's procedure?
That is pylorus preserving pancreatitis, sir.
Why specifically pylorus preserving pancreatitis?
Sir, that is the modified pulse.
No, why you want to do? Why can't we do classical pancreatitis?
Sir, we can do, sir, but nowadays.
So you specifically told modified only, means you have some reason why you are doing only modified Whipples.
Nowadays, pylorus preserving pancreatitis. So I told that.
No, we are doing classical pancreatitis only. We are not doing modified.
So I think.
So you will do, in these cases, you will do first diagnostic laparoscopy always.
Yes, sir.
Okay, when you ask about surgery, what you will do, you first tell diagnostic laparoscopy and proceed to Whipple's pancreatic duodenectomy. Because if you in diagnostic lab, if you see already there are metastases, there is no role of going for Whipple's pancreatic duodenectomy.
Yes.
Whipple's pancreatic duodenectomy, pylorus preserving Whipple's pancreatic duodenectomy. I think there is no word. I think Hazrat should tell me. I think there is no word like modified Whipple's.
No, there is no.
No word. Basic means I'm telling you as a general surgery resident, don't go into all this pylorus preserving, non-pylorus preserving. Examiner will ask you. Just tell Whipple's pancreatic duodenectomy. You are 60% you are right. 60% you are right. Your passing marks are done. Then this all will come. Pylorus preserving, non-pylorus preserving. What are the trials? What are its implications? What are its complications? SR rightly told, Professor rightly told. What are the drawbacks? So in exam is always be simple, be to the basics.
Okay.
That is the only thing in a funda in exams.
Okay.
Yeah,
I think you have excellently done.
Yeah.
But we drilled you. That's the only thing.
Done well, but you decrease your speed when you are doing case presentation where you are telling the history. You should be very slow and confident.
Okay, sir.
Okay, you are going very fast, so catching up will be difficult.
Okay, sir.
And be simple. Be simple. Only basics. Very, very simple thing. Nothing. Yeah. Very, very easy. Be very simple. In your answers also. Let the examiner ask the leading questions.
Okay,
so that you will have more questions. You will be passing easily.
Okay, sir.
Senior faculty, thank you. Would you like to have any more questions or give your closing comments? Vikas bhai?
Yes, he's done pretty well, answered most of the questions, and he at least is aware of whatever we were telling him also, although he may not have answered certain things, but it's a good presentation, I will also say. Yeah.
Thank you, sir.
Vikas sir, these boys are in second year actually. They have one more year of general surgery left because the final years these people have just come enter into third year. I'm sure they have ample time to improve on. Dr. Hari, you should make note of today's questions by all the faculty.
Yes, sir.
They are trying to improve your knowledge levels at particular zones, right?
Yes.
Being
sir.
general is good. Now it is time for you to catch up for NEET super specialty examination. Either you take up oncology or surgical gastroenterology, is your choice. But the depth of the knowledge, that's what all the faculty are expecting from you. Please take note of where are the areas you got stumped. Go back tomorrow, sit in the library, refresh those information and improve on. That's how we keep improving on every presentation.
Okay, sir.
All right.
Okay, sir. Yes.
Hari, do you have any doubts to be clarified with the examiners?
No, sir. No, sir.
Feel free to ask. This is a time for you to get clarified. Rajiv sir, Kanna sir, any comments? I could see Nishi joining in. Nishi sir, any comments from your side? So, Sujay, are you with us? So thank you very much. And I should have special thanks to Dr. Aditya Kalyan, very good friend of ours. Right now, a surgical oncology postgraduate at Chennai. He really has kindly introduced the two senior faculty chair for it. And thanks Aditya for bringing them to the PG clinics. I request all the senior faculty to consider joining us at least once a month or so that these classes go on. And the general surgery post get an exposure of what is happening in the super specialty and how they have to answer in the better possible way. Thank you, Dr. Hazrat. Thank you, Dr. Adi. Thank you, Dr. Sandeep. And thank you, Raghunathan, for joining this evening. Vikas is our good old friend, a senior colleague of ours in our own hospital. Thank you, Vikas. Yeah, if I in fact called Vikas few hours before only, he was gracious to kindly accept. So with that few words, I call the session closed. I'm sure we will have more cases in the upcoming Fridays. This happens all Fridays. So whoever is available on Fridays, you are please welcome to join us. This is an open forum. So don't feel embarrassed or something to feel join us. At your convenience, you are welcome to join. And I also request your postgraduates, whoever is interested in presenting here, are welcome here to present a case here. We'll be happy to accommodate them as early as 1 week in advance. So thank you very much. And I thank sincerely all the faculty for having spared their precious evening time with us for this cause. Any other faculty would like to take any comment, or can we call a close, please?
I had just one more thing for the boys.
Yeah.
Should probably go through some surgical oncology clinics or surgical clinics on pancreatic
Because
surgery.
I request you to share that link. No, I think you people are doing for the DNB for the surgical oncology regularly on Thursdays, if I remember right?
I have no idea.
Okay, there is one for
In
surgical
Saturdays
clinic
is there,
which is
sir.
happening.
For surgical onco, it's Saturday, and for surgical gastro, it's there on Friday.
Okay. Sir, if you have, you can share it to my WhatsApp number, sir. I will be glad to share it to all the students so that they all get benefited.
Sure, sir.
Thank you very much, sir.
Voice.
Thank you. With the permission of the faculty, we call the session a close, and we will hope to meet next Friday. Thank you very much.
Yeah, Kanagavel, that stomach case is not there
yes,
today.
Because sir, today only one case. Before you joined, I told probably that girl had some emergency in the hospital, so they asked all the postgraduates to come. She is from a place near Bhubaneswar, so it looks like there is some local disaster. So all the postgraduates have been asked to come to the OT, I guess.
Okay.
We will have it next week. I'll inform you in advance.
Okay, right.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you very much. Thank you. Good night, everyone.
Thank you, sir.
Good night.
Good night. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you very much. Bye.